Thank you. I want to acknowledge a couple people in the room before I get started. Brooke, I wouldn't be here without you. Thanks for the encouragement and reaching out last fall and suggesting that I do a talk on a pharmacy and implementing a pharmacy, bringing on a pharmacy to your clinic. And Beth, I can't thank you enough for all the help that you've given throughout this process. Beth is our COO at Crossroad Health Center. So I know, she's amazing. A little bit about myself. I have been a pharmacist for over 3 decades and got lots of kids. Once the kids moved out, I took on a whole lot of other projects. I call them my little babies. And then I've had a wide variety of experience in pharmacy. Started off in retail pharmacy, and then I went into nursing homes and independent pharmacies. And I always envisioned having my own pharmacy. And in fact, worked with a local pharmacy for a year to create my own. We were going to partner together. And after a year, decided that we had different priorities and it wasn't exactly how I would have done it. So I am grateful for the experience. I put in a pharmacy last year at another clinic where I get to work. And then I'm helping with this one. But some of I'm getting to create my own pharmacy the way I always envisioned it. And I think one of the biggest problems in pharmacy is we don't have access to all the information we need, such as what are all the patients' diagnoses and what are their lab values. So I make sure that the pharmacies that I work with will have that opportunity and information. So this definitely falls under Christian or services that we can offer to our patients to help us expand our mission and expand services that we can provide at the other clinic where I get to work. Probably going to mention them a couple times because we opened 1 year ago. We're already adding on podiatry. We're looking at nutrition. We've added on spirometry. We've added on Cologuard services. We've added on retina views, all through the funding of the pharmacy. And so the Bible verse that I chose was, "And do not forget to do good and to share with others. With such sacrifices, God is pleased." I like to say God, Google, and grace, and that has gotten me to where I am today. And so being able to help spread my mission and put my vision into place as far as creating a pharmacy where patients can have access to affordable medications right there where they're getting their health care is just really important to me. I'd like to get an idea of who I have in the room. Is anyone not at a clinic here, working in a clinic? Are there any pharmacists here? Welcome, lone pharmacist. And then how many have a pharmacy already in their clinic? Good. And if not, why not? That's why you're here. So I hope to answer more questions. I want this to be interactive. I'm going to give my spiel. I don't have that many slides, but it's one of, I was talking to somebody at Lawndale today, and she says that the pharmacy helps fund the rest of the organization. This the one powerhouse that's really bringing in profitable revenue. Speaking to the accountants in the room. This is a little small, but FQHC entity-owned 340B pharmacies provide access and affordability for medications. And if does anyone have contract pharmacies here? Okay. The benefit of having an entity-owned pharmacy versus a contract pharmacy is you have access to more medications. And so the formulary is much larger if you want it to be. Right now, we have a contract pharmacy that we're using at Crossroad Health Center, and our least expensive insulin is $45. And that's just not necessarily affordable for the patients in our population. So owning our own pharmacy, we can get it for 10 cents and then pass those savings on to the patients, providing an additional stream of revenue that will enable the clinic to provide more services. As I mentioned, we've just added a podiatrist. We're looking at a nutritionist. Having a clinical pharmacist on staff would be ideal, and they can help manage chronic disease state medications, spirometry, retina view. We have a lot of those services already that we're blessed to provide at Crossroad Health Center. but it just makes it affordable. It gives that revenue stream that can purchase those types of additional services so that our patients can get all their care under one roof. Having a pharmacy aligns with the Christian missions to serve underserved populations. It's really awesome to be able to see patients cry because they haven't been able to afford their medications when we can give them the medications that they need. And then the opportunity to connect with patients and continue to integrate faith, whole person care, and patient-centered healthcare. And that's part of creating these pharmacies and giving them access to the EMR, giving them access to providers to ask the questions. The other pharmacy, she had a medication that's normally prescribed once a day or twice a day, and the doctor sent it over as once a day. And so it was for flu, Tamiflu. And she's like, that's not right. And I said, well, she's like, I looked in the EMR and the kiddo's positive for flu. And I said, you know what the dosing is. You're a doctor of pharmacy. You went to school for this. Tell the doctor that you made the change. You have all the information that you need. So, or because the physician was off on that day. So it's just been really good to have more information to be able to take care of patients. Benefits overview, I've already touched on a couple. Cost savings, improved patient care. When patients can't take or afford their medications, they're not going to do as well. Financial sustainability with the 340B program, and then mission alignment. Whole person care, I'm hearing a lot of this past couple days. Having a pharmacy or being an FQHC allows us access to the 340B drug pricing program. And Ben was asking me today, what about the threat of the 340B program? I've been doing this for a while. It's always under threat. I think we've gotten emails for the past 9 years saying it's going to end tomorrow. It may, but we'll continue to provide care and build the resources that we can utilizing the 3 drug pricing program until it's not there anymore. So more affordable medications equal better adherence, and then increased care equity. So we're able to serve populations that may not have access to insurance or affordable insurance and things like that. So that is part of our mission as an FQHC, and it aligns beautifully with pharmacy. The integrated pharmacy and provider communication is one of the best things. Even with a contract pharmacy that we had, there was good communication, and it just makes all the difference for the patients. We can implement MTM, and that's another service that the pharmacy can bill for. And what that is sitting down with the patient, going through all their medications, making sure they understand everything, and billing the insurance company if they have insurance for that service. Personalized medication counseling falls in line with that also. So some of the financial opportunities and support, it can help us be able to add additional services. So in your clinic, if you can think of one service you would like to add, what would it be? Feel free to raise your hand. You've got everything you need at your clinic. It's amazing. I know you don't have a pharmacy yet. I'm just saying, I'm just talking in general. What service would be beneficial for you to have that you don't already have? Psychiatry. Yes. 100% yes. Social work. Yes. Helping with that SDOH. Yes. So help close the gap with the operations portion of the finances. I mean, who doesn't want that? We want to be sustainable, right? Is there anything that you have that you would like to be able to offer? The retina views? Yeah, it's great. We tell our patients to go to the eye doctor. Yes. Her question was, are the podiatry and things offered in the pharmacy? No. It is something that the additional revenue is able to cover, help pay for. Continuity of care. How many times have you gotten a request from a pharmacy, if you're a provider, for a medication that the patient was stopped on months ago? So just having that continuity of care, making sure the patient is still even taking the medications, not and things like that. It's just less reliance on external pharmacies, less reliance on staff having to make those calls back and such. It also strengthens partnerships. And then pharmacies can also bill for the vaccines. So that's a big service that I can't wait to start offering. So the question is that handing the patient the vaccine and coming back to the clinic for administration, or giving the vaccine at the pharmacy? It's giving the vaccine at the pharmacy. Pharmacists are trained to do that. I don't do it at our clinic because we have MAs and nurses who do it, but we're all trained to do it. And the pharmacy can bill for it. They bill for the administration fee and they bill for the cost of the vaccine. And oftentimes, it's revenue generation there too. These are great questions. I can tell you work in pediatrics because you have access to all your VFC vaccines or whatever vaccines. So yes, it does upload to the statewide registry from the pharmacy. So all that information would be current. Working with adults, you'll see things come through for CVS, Walgreens, wherever the patient gets their vaccines. But yeah, it's part of the statewide. Does anybody have any questions or thoughts or want me to expand upon anything? Access to the EMR. So pharmacies don't necessarily have an EMR. We have another software program that helps us to keep the patient's medications on file, submit to their insurance, all the things. And then what we will offer in our pharmacies is access to the clinic's EMR so that they can ask those questions. Okay, this cream is prescribed. The pharmacies have to know how often. If it just says apply as directed, what the pharmacist could potentially do is go in and say, okay, they told the patient to use this once a day at bedtime. So she was just stating that she's getting requests from pharmacies to know what the diagnosis is, which is strange to me because before we're using our EMR, before we prescribe anything, it has to be placed under a diagnosis. So why that's not going through to the pharmacy, maybe that'll be my next project. Okay. So Sam's from Esperanza, and he is asking about that. He's mentioning that he's excited to be able to provide buprenorphine, and asked if we had a cabinet or anything. Yeah, I mean, if you've ever been into the Walgreens, they have buprenorphine there, right? Yeah, so the pharmacies will also, we have a DEA number and went through some rigorous things to get that. It was very challenging and fun. It's also possible for the pharmacy to become specialty certified to actually be able to order in injectable buprenorphine. And so, yeah, we have... Yeah. Yes. Okay. So he's asking, what does it look like if you're not an FQHC lookalike or anything similar, just a charitable clinic? What does this look like? I would partner with other charitable pharmacies. I would imagine that you could probably help start your own. There's resources out there. In Ohio, we have a pharmacy. We're allowed to be a repository for unused medications so that we can dispense them to patients. And so our local charitable pharmacy does take a lot of those back and use them to provide for their patients also. In Cincinnati, it's St. Vincent de Paul. But there's national organizations out there that do it also. They're not going to come into my brain until 2 a.m., but I'll be sure and call you what they are. Something of hope. It's national, and it helps charitable clinics get medications to be able to provide for their patients. Does anybody else have any questions as far as that goes, or adding anything else you'd like to use this funding for? Yes, Brooke? Yeah, so her question is regarding samples. Yes, the pharmacies can store the samples and keep track of those, or it can be done in the clinic. Right now, that's what Crossroad is currently doing. I think it's working out quite well. But either way is fine. Yes. So Sam's question is specialty medications, and would the pharmacy be able to order those in or access? There's some things that we can't get, and we do use specialty pharmacy. Like at the moment, it's Sublocade, which is an injectable buprenorphine. and Brixati, same thing. So those currently we're able to get through a specialty pharmacy. We've got a relationship with St. Matthew's, works beautifully. We could set that up as a 340B contract pharmacy. Also, that would help bring in additional revenue. And I may have mentioned that before, but there's more and more things that we have access to. And like I said, I think it took us 3 days to be able to do the injectable buprenorphines. We had to go through some REMS training at the other pharmacy, and then be approved and all the things. But now we're able to order that in, like Vivitrol, which is an injectable naloxone. We are able to order that in without any special, but that's something that the pharmacy always has in stock. That's another thing she said. Is that something that you're going to stock, or it depends on the pharmacy and what's set up? If you're giving the injections on a routine basis, it makes sense to have them in stock. It's been awesome because, I work in a homeless clinic, and we never know if they're going to make their appointment, but sometimes they just walk in and want that injection that they are a week overdue for. But we just, the pharmacist does keep it on hand in case that happens. So are there any other questions regarding that? It does take about 9 to 12 months to open up a pharmacy. There's lots of regulations involved, as you can imagine, with medications, especially controlled substances. Here are some of the secret weapons besides God and grace that I have used is Noddlepod. I don't know if this is pharmacist only access, but I can go to Noddlepod. I get emails every day about what they are discussing in Noddlepod. And it's everything from operations to how to set up a new pharmacy to 340B to which software to use to, this manufacturer is no longer doing this. How are people getting around it? Or adding on the injectable buprenorphines. I was able to get the information from Noddlepod to be able to incorporate that into a pharmacy. Another one is 3 University that helps bring education around the 3B program, which was created so that clinics could offer additional services to their patients. And then, of course, a pharmacist. I got to plug the profession. So that, and then, Jesus on your side, kind of a big deal. He's really helped us navigate through a lot of the obstacles that we've encountered, and it's all in his timing. Unfortunately, it may not be in Jamie Barron's timing. I do what I can. Yes, I would love to share the obstacles. So last year when I was putting in a pharmacy, it went swimmingly well until we got our MPI number. Here, I've got this pharmacy opening timeline also, a roadmap to help navigate what to do. And I'll talk about a little bit. Well, no, does that make sense? So at the other place, we had to actually do the construction for the pharmacy. And then we brought the board of pharmacy in and they approved the space. And what they had to do was make sure that nobody could get in. Like our walls had to go up to the ceiling. It couldn't just be a drop ceiling in case somebody climbs in the ceiling and steals stuff. Fixtures. Honestly, I got all of our fixtures through donation. The first pharmacy, unfortunately, there was an independent pharmacy going out of business. So I called them. I'm like, hey, what are you doing with your shelving? And they were like, do you want it? And I said, yes. So, and then this time, 2 other independent pharmacies went out of business, donated their shelving to our local charitable pharmacy. And he said, do you want it? And I said, yes. So we've been able to get our shelf, there's plenty of ways to decrease costs as far as the facilities go. So submitting to the Board of Pharmacy, that went swimmingly well. Obtaining our MPI number, the pharmacy has to have an MPI number, that went swimmingly well. Last year, getting our DEA number, I just asked for one and they gave it to us. This year, it took 2 months, and all of our blueprints of our building that's how many years old? 50-something years old, and this, that, and the other. It was quite the hassle. That was our first obstacle that we encountered this year. Last year, our pharmacy information system gave us a lot of headaches, and so did our wholesaler that we were trying to contract with. Apparently, the last 4 digits of your zip code on the HRSA website, it was not the same as what the actual pharmacy was, and so they couldn't give us our wholesaler. I mean, we don't know what we're going to encounter next, but it's just things that you, like I said, just pray. How can I get through this obstacle? Hiring and onboarding. And then, so the Board of Pharmacy inspection in this second column, that's gone really well both times. The controlled substance did last year, not so much this year, but we did get finally through it, thank goodness. And then business permits and things like that. The NCPDP is a number that we need, but we had to have the DEA number. So when we had the delay with getting our DEA number, that pushed back getting all the other things that we needed. So we couldn't even apply for our account with our wholesaler until we had our DEA number. We couldn't even apply for our NCPDP before we had our DEA number. We needed our DEA number in order to choose which software or create the contract with our software vendor. So right now we've gotten our software. We are working on implementing that and setting up our wholesaler. There's something we had to add the pharmacy to the HRSA website so that we can get an HIN number, which is a healthcare like interaction number or something like that. That's what we're waiting on now so that we can get our wholesaler. I'm a proponent of the PSAO, which I looked up a definition because I didn't know how to explain it correctly. It acts as a bridge between the independent pharmacy and the complex world of PBMs. If you haven't heard of PBMs, they're pharmacy benefit managers. They're the bad guys. They really are. And third-party payers and providing the administrative support for negotiating favorable contracts. They help pharmacies stay focused on their core mission of providing care while they take care of some of those issues. Every wholesaler actually has their own PSA, but through NoddlePod, I learned that might not be in the clinic's best interest because it's kind of like they're aligned with the wholesaler. They don't necessarily want to decrease your contract prices, right? Because they're the wholesaler. So it's been really beneficial to have access to mentors and people in this space. I would love to answer any other questions about opening a pharmacy. I'm not sure what you were hoping to get out of this. I'm grateful that you're here. But if there's anything that I haven't answered, I'm sure I can. Yeah, so he's asking, would you go hire a pharmacist before you started down this path? Of course, I'm going to say yes. But there's other companies that you can actually contract with who do this as a business. Typically, they are pharmacists. I feel like having a pharmacist help navigate this process is the best interest of the actual pharmacy that you're putting in, just because there are so many regulations. Jamie, do you think it's been helpful to have a pharmacist? Once this pharmacy's up and running, my deliverable is met. So, I've been helpful, or hopefully, yeah, in getting it going. Thank you. God, Google, and grace. No, nobody learned, not many people, unless they have experienced and gone through this procedure or this path, would know. So like I said, and there's several companies out there who would be happy to contract with a clinic to get you up and running and to help navigate these barriers. Crossroad was just fortunate, I'm going to say, to have a pharmacist already involved and who had been through the process within the previous year. And it's successful. So the pro forma I created last year, that had a 6-figure profit. I talked to the CEO last week and I said, how close was my pro forma? And he said, your expenses were right on, pretty much to the dollar. And the profit, we've surpassed it by a lot. And like I said, the provider I was talking to from Lawndale today did to say that the pharmacy is helping to support all the other, providers or behavioral health or whatever places that may not be as necessarily profitable, but it's so good to have on hand. So good for our patients. And you can always start with a contract pharmacy. There is revenue to be generated from that. However, I would encourage you to use a third-party administrator to help navigate that and make sure that everything's being met as far as the 340B regulations go. If you have an entity-owned pharmacy, it's not necessary to have a TPA, the third-party administrator. It's nice for the pharmacist at the other clinic. She can just go into the patient's chart to see if they are, qualify for 340B savings at less than 200% of the FPL federal poverty level. And she doesn't have to ask anybody. She doesn't have to check it. It's just all right there. I don't think this is my God, Google, Grace, and learning from Nautopod that third-party administrators are not required for entity-owned pharmacies. They can be used, but they're not necessary. So Beth just mentioned it would be imperative to have a pharmacy manager who's familiar with 340B. We're blessed with the pharmacist that we hired. She had worked in a couple other 340B clinics. Pharmacists that used to be at our contract pharmacy weren't necessarily as informed about what the 340B program was about, and so it was not necessarily beneficial. I don't think they got the most out of the 340B program. Yes. So his question is, if 340B gets shut down, would the pharmacy shut down? Oh, heck no. We still have our Medicaid contracts. We still have commercial contracts and can serve our Medicare. And then we could create funds. We could get grants and funding to help support those patients, patient assistance programs, manufacturer programs, repository. We'd probably institute a repository to help the underserved or uninsured patients. Repository is where we can take back unused medications that have been dispensed to a patient. We had 26 Vivitrol at the homeless clinic where I work that were never used because the patients didn't come back. I was able to ask the state, can we use those for our uninsured patients? Because we can't send that back. And so they were like, yeah, absolutely. Primarily St. Vincent de Paul, but you can look up repository locations, and it will give you a list because it has to be registered with the state. I hope this has been helpful. I'm very passionate about it. We're all here trying to serve our patients the best way possible, but we do have to fund that. And so our patients can be somewhat complicated. So being able to offer them additional services just helps with that whole patient care. And then to be able to give them their medications or vaccinations before they leave the building and get reimbursed for that, just a bonus. Does anybody else have any questions? I'm glad you're here. And if there's anything that I didn't answer or any topics that I didn't cover, feel free to reach out or just let me know.